Okay, students, I'm just really going to run through this pain chapter pretty quickly. So here are your learning outcomes for the chapter. So the benefits of comfort and support during labor. So all these things ultimately provide mom with the ability to get through her contraction pains and, of course, deliver her baby and have a positive experience. However, also important is the more we're able to get mom to relax, the more her contractions will be effective. So the tenser the mom is, the more she's holding her breath with contractions, the more she's drawing up her shoulders to her ears, the more she's tensing her muscles, the more difficult time she's going to have dilating. So we want to get her to relax as much as possible. Now, in the early parts of labor, there's some things that we can offer mom to do, help. But then as labor gets into the active phase, and definitely when the labor gets into transition, the mom might find these things to be not helpful enough and opt for some pharmacological support. But right now we're just going to cover non-pharmacological support. Maternal positioning and movement is huge. Like I relate labor pains to, hold on. Come here, Max. Max. Oh, Max, come. So I relate labor pains to like laying in the bed and allowing someone to beat you in the belly with a baseball bat. It's pretty, I mean, that's not what it feels like, but just laying there doing absolutely nothing is horrible. Like you have to do something. So movement and positioning changes are really effective in helping mom find a position that's comfortable. Also, just the frequent position changes and the movements are going to help baby to drop into that pelvis and engage properly. And then a lot of times just being up and moving, even if it's sitting on a birthing ball or in a rocking chair, that use of gravity may facilitate that cervix dilating. So everything sitting down on that cervix. Okay, so there are breathing techniques. And remember, I had those documents in there that you could just review so that you have some tools to help a patient in labor if that's a patient you're taking care of. But breathing techniques are really helpful, and it does decrease the pain somewhat as it relates to when you hold your breath, you decrease oxygen. When you decrease oxygen, that causes tissue to be more painful. So it's not going to take a lot of the pain away, and it's probably not even going to be noticeable, so I don't even mention it. What I do mention to mom is the more you hold your breath, the more the pain is going to be stronger because of the lack of oxygen. So that kind of helps them to keep breathing. A lot of times we have them when you feel the contraction building, take a big, deep cleansing breath, and then throughout the contraction, use some sort of paced breathing. It's not so much the pace it's what it is mom's focusing on that pace. She's focusing on that breathing instead of focusing on the contraction, okay? And then when the contraction is over, then she takes a nice big deep cleansing breath and blows it out. Music is helpful. Relaxation techniques. Someone working with mom to practice relaxation techniques, attention focusing techniques, or using guiding imagery. So have mom go to her, peaceful, pain-free place and think about that place, or have a focal point. A lot of times, like a stuffed animal they bought for the baby, or a picture that is very significant and important to the patient. Like when she has a contraction, to focus on that picture, to think about those things in that picture. When we engage our mind in other activities, it takes the focus off of the pain. Okay, so that is helpful in getting through pain. Okay, Ethel-Raz or gentle stroking. I like to use this on the woman's shoulders and down her upper arms, just as a reminder to relax. Okay, not so much that this is helping anything as it's just promoting relaxation in that upper part of her body. Counter pressure is very effective. So using a fist or the heel of the hand or a tennis ball in that sacral on the in the sacral area of the lumbar, even the lumbar spine, wherever she finds it's good, you just put constant pressure. Maybe you will do a little bit of a rolling motion, like almost not even a motion at all, but whatever mom says, yeah, don't move, or just a little tiny roll, like almost incomprehensible roll. That can be helpful. Therapeutic touch, if you're trained in that. I'm not, and I don't know any of the OB nurses who are, but sometimes doulas are trained in therapeutic touch, or the patient may hire a person whose practice is therapeutic touch and using them to help them, but I've never seen anybody bring one of those. And same with healing touch. It's just another I really am not sure of the difference of these. One is touching and one is actually not touching. One is right above the patient's body surface, wherever that is, and I can't know which is which. But anyways, those are options. Hydrotherapy, which is basically getting in the jacuzzi tub. We have those for patients. Hypnotherapy. So people who are trained in this are more therapeutic, and I've really not seen it ever being used, but so that could be a possibility. Aromatherapy, and they can bring their own, and we do offer aromatherapy. I can't remember what. I know we have peppermint, which helps with nausea and vomiting for our patients who have that problem. But I don't know as far as labor pains what we have. I think we only have like 1 or 2 different essential oils for that. So, and then we have a diffuser. So they can use ours or bring their own or whatever. Application of cold or heat, so whichever feels good to the patient. Cold for the forehead, maybe the back of the neck, because labor causes patients, it's hard work, so patients get hot and sweaty. But maybe warm rice bags to the lower back, or whatever. Biofeedback, just concentration, using focal points and breathing, and then the partner recognizes the cues and uses verbal feedback to guide the patient. So this is really a two-partner, and if the couple is trained in using this, of course, we will support this happening. And TENS, we don't have any of those. The patient may have their own, and if they bring it in, they can certainly use it. Intradermal water blocks. So this is something that Kathy mentioned when she did, Kathy from the Birth Center mentioned when she did her little presentation for you all. Intradermal water blocks. So they're 4 small injections. 2, they're, okay, so they're, do I have a picture? Oh, there we go. Sorry. So this is where you would do those injections. So you hopefully would have 2 people doing these. So you would have 2 people so one person doing this, one person doing this simultaneously, and then one person doing this site and one person doing this site simultaneously. These are very temporary. These work on some people. Some people don't find them beneficial at all. I find them beneficial. I have a chronic back problem, and when I was working on the floor, and I'd have a shift where I was doing a lot of standing and bending and leaning, my back would really be inflamed, and I would have nurses do this for me, and it would give me a little bit of relief. Acupressure, kind of like, where was that, where we saw about the tennis balls, back here, counter pressure. Acupressure is similar in that they use pressure points on the neck, shoulders, wrists, lower back, hips, even the kneecaps, ankles. Someone who's trained in acupressure and knows where, you put that pinpoint pressure and it helps another area of the body, kind of, sort of. So someone who's trained in that, the labor patient can have that person come in and provide acupressure. Acupuncture uses the needles at specific points, and that helps. But a patient would be more than welcome to do that, but a trained person would need to do that. So, all right. So there's some non-pharmacological, and other non-pharmacological is the use of the birthing ball. I think your textbook shows, like, when we talk about positioning, we're not just talking about different ways to lay in the bed. So the patient can be standing, she can be holding on to the wall rail and rocking her hips. She can use her partner, and they can do like a dancing movement where the patient is kind of hanging on the partner and doing that through contractions. And so there's just all kinds of things a patient can do as far as positioning and little activities like that they can do to help with labor pains. Now, pharmacological options, timing is important, because if we give these pharmacological options too early, we could slow down labor. And if we give them too late, depending on what they are, if it's a systemic medication, it will cross the placenta and infect the baby. So if we give it too late, where it's too close to the birth of the baby, and it's something that causes respiratory depression in the mom, it will also cause respiratory depression in the baby. Now, informed consent is the only time we get informed consent is when we do the epidural, but definitely, you're not going to be giving narcotics or IV pain medicine or any of those kind of things without the patient's consent. Now, some different types of medications that are options but not typically used, like sedatives and antiemetics. We can give sedatives alone or with an analgesic. We can give antiemetics alone or with an analgesic. So they, in combination with the analgesic, kind of potentiate the analgesic's therapeutic effect. But if a woman is in early prodromal labor, and she's a patient in the hospital, and it's nighttime, and she needs to get some rest, but she can't because the contractions are frequent enough and uncomfortable enough to keep her awake, but they're not purposeful cervix changing contractions, we would maybe offer her a sedative to sleep, Ambien, to sleep, and then when she wakes up, then she's rested and has some energy and and has strength and energy for her labor. Antiemetics, so a lot of women vomit during labor, and we can give antiemetics. But typically what happens is the woman isn't nauseated so much as all of a sudden she vomits. And then when she vomits, then she's not nauseated afterwards. So the antiemetics really aren't that effective, I feel, in labor. If she is nauseated, yes, they are very helpful. But typically in labor, a woman's sitting there talking to you, and all of a sudden she says, "Get a bucket, I'm going to vomit." So, but they are very helpful when you use them with a narcotic. Barbiturates, like, we don't use any barbiturates. They're used for sedation. We don't really do that. It causes more problems for mom and babe than it does, than it's a benefit. So I don't even know why it's in here. It's presented in your text. However, you should know about barbiturates because of pharmacology, but they really don't have a place in obstetrics, okay? Benzodiazepines, so Valium and Ativan, yes, sometimes we use that for the very, very overly over-the-top anxious patient. We will give that to treat anxiety, but and it does enhance your analgesics, but we don't use it to enhance our analgesics during labor. But if we had a patient that was really coming uncorked for whatever reason, we would give her a dose of Ativan, calm her down, and go on with life, okay? But it's pretty rare. H1 receptor antagonists, so your Phenergan, your Vistaril, we give those a lot, and Benadryl, of course, for their antiemetic effect, their sedative effect. And also for, sorry about that. Like the Benadryl, we may give after labor if a patient is having a lot of itching related to, that is a side effect of epidural and a special side effect of of a spinal, they may itch. But a lot of times with the epidural, we don't give it when they're in labor and they're itching because of the epidural. We don't want to provide that sedation to mom or baby. So they just kind of tolerate the itching. After they deliver the baby, the epidural is wore off, the itching has wore off. Okay, so that's really not a problem. So we rarely give it post-vag delivery. But with C-section, that spinal, sometimes that itching is really intense, and and that spinal will last for 24 hours. So we can give Benadryl. You will see us giving Benadryl to some patients after C-section. Phenergan and Vistaril, of course, they're antiemetics, but they also are excellent potentiators of, like if we were to give morphine or Demerol, which we rarely do anymore. We used to give morphine and Demerol a lot during the early days of my career, and we'd give it with Phenergan and Vistaril, 1, to potentiate the therapeutic effect of the narcotic, but 2, to also decrease the side effect of that narcotic, which is nausea and vomiting. Okay, moving on. Analgesia versus anesthesia. So analgesia is a relief of pain, and anesthesia is a complete or partial loss of sensation, with or without consciousness, and which affects the ability to detect pain. Okay, so for our analgesics, we have opioids like Dilaudid, Demerol, fentanyl, Sufenta, morphine. Those are all options. However, fentanyl is the drug of choice in labor. So different parts of the country favor different medications. So Sufenta is a medication that I've used in Wyoming to go into an intrathecal for a patient. So, and rarely would we use the Sufenta as an IV medication. It would usually go in our intrathecals. But fentanyl is the drug of choice for IV administration for pain relief. 50 to 100 micrograms given every hour as needed for pain. Now, what typically happens is the patient will ask for the fentanyl, you'll give it, and they will have really good relief. And then an hour or 2 hours later, they'll ask for another dose of fentanyl, you'll give it, and it won't work as well as the first dose. Now, is that a consequence of recurrent fentanyl administration, or is that because the contractions are getting so strong that the fentanyl is not strong enough to help? Okay, so it provides a pain relief. It delays, the side effects, delays gastric emptying. Emptying can cause nausea and vomiting, diminish bowel and bladder elimination, which we don't really care about the bowel so much, but we definitely want the bladder to be eliminating. Dilaudid and Demerol we can give every 2 to 4 hours. We don't typically do those in labor. We usually just use the fentanyl. Okay. Sufenta and fentanyl. I said Sufenta was a drug that was used in intrathecals in Wyoming where I worked. We rarely do intrathecals here in Montana. As a matter of fact, maybe 1 or 2 I've ever seen done here since I've been here since 2013. The anesthesia of choice is an epidural, and when we use an epidural, we use fentanyl. Fentanyl is a narcotic. So when you use when you do an intrathecal or spinal or epidural, you'll use some sort of local anesthetic, some sort of cane, and we use bupivacaine. Well, bupivacaine, of course, any type of cane, lidocaine, bupivacaine, or rupivacaine, or whatever all those names are, canes, they numb. Okay, so they decrease sensation, they numb it. So if you did nothing but bupivacaine in your epidural, then you would have to use you would be having complete sensation loss. Okay. But if you put a little narcotic in with that bupivacaine, one, you wouldn't have to use so much of the cane, which causes complete sensation loss, and then you would be getting the benefit of, the cane, sensation loss, and pain relief from the fentanyl. So that's what they do now is, so our epidurals, patients can typically move their legs and they can kind of feel their legs and stuff like that, but they're not a complete, it's not a complete sensation loss. Sometimes it is, but that's kind of the rationale for using narcotic in with your epidural cane. All right. So side effects for your analgesics, your opioid systemic analgesics. Oh, I'm sorry. I'm sorry. I'm not talking side effects. So other opioids that they can use are Stadol or Nubain. I use Stadol a lot in Wyoming. Never, I don't think, have I used it here in Montana or Nubain. And I know they used in West Virginia, where I came from, at least at that time, they were using Nubain a lot. It has a less of a respiratory depression than your fentanyl and your morphines and Demerols. It causes less nausea and vomiting, but may cause more itching. And let me see. The reason why we would use Nubain here is Nubain is effective in treating the itching after C-section, after your spinal, but I don't even know if we can get Nubain anymore. So I know like 3 years ago there was a shortage of Nubain, so I don't even know if they're making it anymore. So now an opioid antagonist, so the reversal drug, so if you give too much systemic opioid and cause respiratory depression in mom, you can give Narcan, and that will reverse the respiratory depression or the CNS depression. But it'll also reverse the effects of the pain thing. So, and you know, Narcan is the drug that they supply for drug abusers on the street so that they don't overdose. All right, now let's move on to regional anesthesia, temporary and reversible loss of sensation. So this is our epidurals, our spinals, and our combined spinal epidurals. I'll kind of explain that here in a minute. But we use, like I said, we use the narcotic with the local anesthetic so we can somewhat limit the loss of sensation effect of the regional anesthesia. Now there's also a local perineal anesthesia, which is called a pudendal nerve block, where we use lidocaine, and we inject the pudendal nerve with lidocaine, and I'll show you a picture of that. We don't use that very often. It's kind of difficult to give. The obstetrician gives it. We give it when the woman's pushing, and if she has very poor pushing efforts because she's easing up because it's hurting so bad, we might give her a pudendal nerve block so that we can get back to effective pushing. All right. This is the pudendal block. So they got to get in there. It's a super long needle. It's a whole device type thing needle. It's in a kit, just like an epidural would be. And they have to reach in there. They have to reach in vaginally, find the pudendal nerve, and then inject, okay? And like I said, we don't use those very often, but please be aware of those. Now, this is the injection sites for our spinal and our epidural. So this is the spinal space right here. And this is where, or they call it the subarachnoid space, but I call it the spinal space. This is where the spinal fluid is. This is where your spinal nerves are. Well, they're up here, but this is at L3, L2-ish area. This is where they would inject for, well, yeah, this is where they would inject for their spinal. This is also where they might inject for the epidural. But just know that this little space here, this is called the epidural space, and that's where they will, this is the space that they go in to do the epidural, but it will probably be higher. So with the spinal, they inject the needle, and then they inject the medicine, and then they pull the needle out. So with a spinal, there's nothing left in the patient's back. With the epidural is just like an IV catheter. It has the needle and the catheter that is over top of the needle. So the needle, excuse me, the needle gets into the epidural space. They thread the catheter through the needle. I think I said it backwards. They thread that, so they get the needle in place, and then they thread the catheter through the needle. So it's like an IV, except backwards. So on an IV, the needle is over the catheter. You get in the site and you pull the needle out. This is backwards. You put the needle in, thread the catheter through. So you would thread the catheter through this port, okay, and then you would pull the needle, and then you get your catheter in place, and then you pull the needle out, and it pulls, you have to pull it out, all the catheter that is going to be taped to the patient's back. Okay, I hope I didn't totally confuse you. So a spinal anesthesia, they go in third, fourth, fifth lumbar space, they inject their dose, and pull the needle out. So we can see here that we are, with that, for a C-section, we would be numbing through the T8, S1 areas. We don't want to go above T8 because we start getting into diaphragm innervation and infecting a woman's respirations. And in a vaginal delivery, we will do T10 through S5. That's what we're numbing, the nerves that innervate or come from those areas. So spinal anesthesia, easy to administer, smaller volume because you're just injecting the medication and pulling the needle out. Mom can stay conscious. Complications. So this is the big one, maternal hypotension. When we have maternal hypotension, that leads to decreased placental perfusion, and then causes baby to have problems. And then, so let me talk about that first. So with a spinal and with an epidural, we will give mom a fluid bolus right before anesthesia comes and starts the procedure. And that is to minimize the maternal hypotension. But even when we do that, we sometimes end up having maternal hypotension. So we'll talk about that more in a little bit. But we want to we want to give mom a fluid bolus before the procedure. Now, after a spinal, a patient can suffer from a spinal headache, a post-procedural spinal headache. And if she has that, her signs and symptoms for a spinal headache is, she's laying there after her C-section, she's had her recovery, we move her to postpartum mom and babe, and she starts feeling a lot better, starts sitting up in the bed. So we elevate the head of her bed, and then she's like, oh my God, my head's going to blow off my shoulders. And then we put her head down. Oh, that feels better. So that's a spinal headache. And to treat spinal headaches, we need to do what's called a blood patch. And we need anesthesia to do this, and the RN, and it's done under sterile technique. So under sterile technique, the RN will, she will do a venipuncture, usually in the anticube, the easiest, biggest vein we can find. And she will draw 10 to 20 cc's of blood, sterilely hand that off to the anesthesia, who is at the woman's back like he was when he did the spinal, and he injects that blood into the spinal space, just like he did the medication, and that clots off whatever little leak she was having to cause a spinal headache, and then replaces that fluid volume as well in the spinal space, and life is good. Okay. So if she's going to get a spinal or an epidural, she has to sign a consent. So we need to make sure we witness that consent. We give that fluid bolus before. positioning for the patient. So the majority of the anesthesias like the patient sitting on the edge of the bed, and then they like the patient to kind of round around their belly and stick the lower part of their back out like a mad cat. That helps open the vertebra so that he has a clean shot at those spaces he needs to get to. And then we sit there with the patient while he's doing that, because she may be contracting during this procedure and we need her to stay still. So a lot of support for the woman to get through her contractions without moving and causing a problem for anesthesia in placing this epidural or spinal. And then post-procedure, we immediately lay the patient flat, well, head down with a little left tilt, keep her off that vena cava. And then we do frequent serial blood pressures on mom for 30 minutes to make sure her body, that she doesn't go into that maternal hypotension. And then we can start raising her head and letting her be comfortable and whatever throughout the rest of her labor. So we're going to do frequent assessments on mom, vital signs, watching baby's heart rate, watching contractions. We can help reposition the patient after that initial 30 minutes. We can sit her up. We can turn her to different sides and stuff like that. And then when it's time for her to start pushing, then there's a lot of assistance that we need to do. Okay, so especially if she has a really dense epidural. In other words, she really, really, really is numb and we're ready for her to start pushing. We may need to coach her with pushing, and, say that wasn't very good. Oh, that was very good. Do it that way. Try again, blah, blah, blah. And then when she starts getting the feel of it, then they're a little bit more effective. But if a patient has such a dense epidural that they don't even feel the urge to push, then we might let them labor down. I don't know if I mentioned the word labor down to you before, but this is a woman who's completely dilated and would be ready to push, but because that epidural is so dense and she doesn't feel that urge, we will let the contractions push that baby down. And there will be a point at which mom is like, oh, I feel something. I think I could push. And then we have her start pushing, okay? All right. And then so here it talks about that spinal headache. Yes, you can give analgesics, but typically they are not effective. And, bed rest, dark room, maybe try caffeine, hydration, but if she's got a true intense spinal headache, a blood patch is usually the treatment of choice. All right, and that's because of leakage of spinal fluid, and it gets worse when she sits upright. She could have auditory or visual problems, and so we do the blood patch, which I already described to you. Okay. Now, local anesthetic, I've already said that the local anesthetic is bupivacaine, and we have the kind that is with fentanyl. However, synfentanil can be used as well. We'll go into the fourth or fifth lumbar space. It provides complete pain relief through the duration of her labor, and then after her labor and she's birthed her baby, we turn off the epidural, and it takes an hour or two for her to get her sensation back. When we have an epidural, we have a bag of medication, and it's just like having a bag of fluid or an IV antibiotic. We put it on a special pump and we set it to a drip rate, and usually that drip rate is 10 to 14 cc's an hour of medication. So that's constantly dripping in throughout her entire labor. And then we also set it up where she could administer a PCA dose, a patient-controlled administration dose. And we program the machine to give her a certain amount. It gives her a quick bolus if she's starting to have a little bit more intense pain, okay? We've already talked about the hypotension. So disadvantages of an epidural is limited mobility. So depending on how much bupivacaine and how much she's able to move herself, but because of the limited movement, we need to go in and reposition this mom every 30 to 60 minutes. We don't want a mom being stagnant in her positioning, because that may affect baby's descent. If we give the epidural too soon, it might lengthen the labor, but we have Pitocin, so we can fix that. Common side effects are the itching and the orthostatic hypotension, which we've already talked about. Accidental injection into the blood vessel. So the anesthesiologist, before he injects the medicine, he aspirates on the needle, makes sure that he's not getting a blood return, that he's not in a blood vessel. But if something happened and he did, then the woman's behavior would be very bizarre. She'd be disoriented, maybe even have seizures or convulsions. Oops. So a woman can also have a severe hypotension that we've already talked about, causing significant problems with the baby. We would end up having to treat the mom's hypotension, put mom's head flat, give her oxygen, give her a fluid bolus. Those are things that you would do for anybody who has a hypotensive crisis. And then also we would maybe administer IV push ephedrine, 5 milligrams, can be repeated every 5 minutes or 10 minutes. Anesthesiologist is usually around when this happens, and they are usually the ones that are administering it, but the nurse can also administer it. Causes urinary tension and bladder distension, mainly because she can't feel the urge to push. She can't feel the urge to void, so she doesn't have the letdown reflex. This is why these women usually get an indwelling Foley catheter. Other nerve blocks, so the spinal epidural combination. So what would happen was we have a patient that's really out of control in pain, and they will put that needle into the epidural space. They will inject medicine. They will pull the needle back to the epidural space, thread the catheter, and place the epidural. So simple. Intrathecals, so it just goes into a different space. It's very similar to a spinal. It goes into the intrathecal space. They inject the opioid, pull the needle back, or pull the needle out. And then with an intrathecal, women can get up and walk around. So that's why we love them. That's why I love them so much. But they usually don't last the entire labor. They usually only last 2 to 4 hours. So depending on when you give this, it may wear off. And so people that do use intrathecals, they usually say that a woman can have 2 during her labor. So so you try to plan these at the ultimate time so that she doesn't get done with her second and then still have labor and contraction pains and then be not good. So Sofenta is usually the drug that's used for these intrathecals. I've never used morphine in any of these, and we've already talked about the pudendal block. General anesthesia is reserved for those absolute emergency C-sections where we don't feel we have time to get the spinal in. But most of the time we do have time to get the spinal in. At least we try to take the time, because there's a lot of side effects for mom and babe for use with general anesthesia. When we use general anesthesia, it can increase mom's blood loss because of relaxing the uterus. So then we're going to have problems with postpartum hemorrhage. It can cause hypoxia and aspiration in mom. And then it can cause fetal depression. So if you're doing a stat C-section because of a bad baby, and then you give that bad baby anesthesia on top of that, then it could be really, really, really catastrophic for the baby. So we try not to use it unless we absolutely have to. One other time I've seen this used, besides the absolute stat C-section, is with a patient that anesthesia has done everything they can and they can't get the spinal in. They can't get the spinal in. Like, if you can't get the spinal in, then the only option is general anesthesia. Anyways, so of course they would get IV fluid before. With anybody that we're having surgery, we usually give them Bicitra because they're laying flat, and we want to decrease the gastric acidity. So we'll give Bicitra. We'll also give Pepcid and Reglan in some cases. Usually it's Pepcid and Bicitra, but some anesthesiologists also want us to give Reglan, especially with general anesthesia. It increases gastric emptying, so that would be helpful. But anyways, any OB patient that's going to be having surgery, no matter what kind of anesthesia she's getting, we have a hip wedge in the OR that we put under the patient's right hip to put them on the kind of a left tilt, and then they're always getting oxygen. Now, if she has general anesthesia, she does need to be intubated, and the RN may need to apply cricoid pressure to assist anesthesia in placing that tube. We've already talked about fetal depression and blood loss. So these are the gases that we would probably use. I'm not concerned about you learning these gases, but just know with general anesthesia and these gases, the patient is at risk for a malignant hyperthermia. So we would have to be aware of that risk and be able to care for that patient. If the patient has general anesthesia, she will go to the PACU recovery room with PACU nurses. If she has just a spinal anesthesia, then we can recover her. OB nurses can recover her on the unit, and that's in both hospitals. Okay, so generally the recovery is, we're maintaining the open airway until the patient is absolutely recovered from anesthesia and can maintain their own airway. We're oxygenating them. They are on a cardiac monitor. And that also monitor also has the capability of watching their blood pressure and oxygen saturation. And then we're going to be really doing a lot of assessments of her fundus and her lochia, making sure that we are not having a postpartum hemorrhage. And then as soon as mom is able to, we will get baby on mom's chest, bonding and breastfeeding. There have been times where I've had a patient who was recovering from anesthesia. It really wasn't with us yet. And I was holding baby on the breast as the baby was breastfeeding. So mom might not be able to be doing this yet, but we as the nurses can definitely help support that. And then, emotional support, answering questions, support family, blah, 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 blah. Oh my gosh. Okay. So these are diagnoses you can use for your patient for pain. Oh, I'm done. Okay. So, good luck on your exam. Okay. All right. Thanks.